So, ladies and gentlemen, we have a very, very distinguished panel of speakers, all of whom are scientific directors or chief executives of their cancer centers and/or university hospitals, cancer centers within university hospitals. Many are internationally well known. We have here on the far right Joseph Tabernero from the Vall d'Hebron Cancer Center, which is actually within a university hospital and took some years to develop the cancer center, but two very strong scientific institutes in Barcelona, which are all part of the cancer center. Here from Helsinki, our host for these few days in Helsinki, Johanna Mattsson from the Helsinki University Hospital, the chief, Leena Triin-Korve from Estonia, from Tartu, who is basically the boss of that cancer center, and Frédéric Panos, sorry, I need to revise your name, Lorca, yes, from the Clermont-Ferrand Cancer Center, which has recently come into the OECI program, and it's great to have you here too as well. And Gennaro Giliberto from Roma, the Regina Elena Cancer Center, was previously scientific director in Napoli as well, both of which centers are within the OECI program. And finally, John Kennedy from Trinity St. James's, Dublin. So we've got a variety of cancer centers here in Europe. And the main question, the first exam question for you all, please, and I'll start, if I may, might as well start logically with you, Joseph, is, in your view, and this can be anything, this can be on cancer care, it can be on cancer research, it could be organization, it could be on education, it could be on staffing, it could be on finance. What are the main issues as a cancer center director that you're facing, and how can OECI help in that process? Are there resources we can give or collaborations we can help to create to help meet some of those challenges? And I'll take a few notes as you speak.
Well, thank you very much, Simon, for organizing this session. And first of all, I just want to disclose that I come from, as you mentioned, from a general hospital, an university general hospital with a comprehensive cancer area that is very big, but understanding that our center is not a cancer monographic center. So basically, there are several quality challenges. I would like to start with them, right? And especially some of them are very functional, operational, I would say, but some others are more strategic. And I think that, just to put an example, I think that with the burden of cancer right now, problems or challenges that we face, like the delays in the diagnostics, also delays or waiting lists for surgery or for some therapeutic procedures. Also implementing programs that need collaboration with primary care, like, for example, screening programs or early diagnosis programs. So these are clear operational challenges. Of course, research, especially for funding, protecting time for physicians, nurses, clinical scientists, in order to promote academic science and academic clinical trials. It's very important. But I would say that also in the conception of the Comprehensive Cancer Center, we had to address from the early beginning strategic issues, right? And I think that it was really very important to define our SWOT, especially the vulnerabilities of each institution. I think that was especially important. Thinking also on plans on the mid-term and the long-term basis, because usually in hospitals, especially in general hospitals, we are more focused on the short-term basis. And actually, if you want to build something for the future, for the patients, for the quality of cancer care, you have to think more on the mid-term basis. Actually, in our country, also involving the patients was a challenge from the beginning, not right now, but having patient advocates, not only in the decision process of the disease that the patient has, but more importantly in co-creation, right? In creating new actions, new plans involving them, That was a challenge, but we have improved on that, and I think that was fundamental. Also, we had to face with internal communication issues. Big hospital, more than 1,200 beds, 10,500 professionals working at the institution. It's a challenge, and sometimes you create, for example, SOPs for problems, for pathways, but if you don't communicate them among the institution, among the professionals, that's a problem as well. So we had to do a lot on coordination, improving our tumor registry as well. This is fundamental, of course. And one thing that I like very much when you propose all the path for the accreditation, actually the concept of interfacing and glues, no? So putting glues that would allow the different departments, the different services collaborate much better, and especially with primary care. And perhaps something that we had implemented before even, but I think it's important for, maybe important for some of the institutions actually, is to create a clinical trials office to promote as much as possible academic research. And on an educational and academic aspect, I think that the defining time, but also defining resources, finding resources for academic projects, especially PhD programs, for physicians, for nurses, for other professionals in the institutions, that it's critical, right? And also in our field of cancer, defining a specialization. I think that this is quite obvious in many countries for physicians, not as much for nurses, and I think that this is really very important in our field. And what actually, coming back to your question, what OSI helped a lot just to tackle, these problems is, defining the metrics, defining the KPIs. That was fundamental in order to improve our way of daily living and daily operational. Also, what was important, and you help a lot, is to share on other models that were available. I remember from the early beginning when you came with the governance, how we were going to have a governance in a general hospital with university, 2 research institutes, as you mentioned. And actually, that was very helpful. And that was at the very high level. But then when we went deep into the problems or the challenges that we had, also looking at other institutions, how they had solved those challenges, that was really very helpful. So we don't need to reinvent the wheel, for sure, right? Many institutions actually have created cancer centers and comprehensive cancer centers, and there is a lot to learn from them, right? As a summary, I think that the question was very open, but that would be my critical points on that.
Thank you, Josef. And I think we will see some comparisons from the different centers represented here. We'll see some common themes coming out. So, Johanna, to you, are some of those challenges similar to, in your experience here leading Helsinki?
Yes, of course, but I think that I will raise 3 points, as our new president in Finland usually expresses himself by telling 3 points. So my first point is that I think that the continuously increasing number of cancer patients makes a challenge for all of us, because we have to adapt our activities all the time to take care of the access to treatment, timely access to treatment. So I think that is a continuous challenge. And another major challenge is, of course, we're happy to get all the time new therapies, and the outcomes for our patients get better. But on the other hand, it's very, very difficult to follow the budgets with the new drugs, for instance. So that is a major challenge. It's a positive challenge on the other hand, but on the other hand, it's a big challenge to be able to evaluate the amount of money needed for your budget and to keep up with the budget. It's almost impossible. And then last but not least, I think it would be very, very important to be able to, in real time, follow up your outcomes. And it helps you also to plan your activities and also keep up with your financing and planning of the personnel, etc. So this is something that I think we are lagging behind because it's not an easy task to build up a system where you can in real time follow your outcomes.
Thank you. If you don't mind me just making a comment on that last point, because when we do the accreditation process of cancer centers, it's often, there's often a weakness in tracking in detail the outcomes of patients, not just the overall survival, although some centers actually struggle with that because in a place like France, the information on death comes from completely different regional registries, takes time to get into the clinical registry, if at all, if somebody's moved or there's mobility. But even tracking more detailed outcomes, MDT by MDT, is a real challenge. And sometimes, you know, the IT people say, yeah, well, we can get that data, but it's unstructured. It takes time to drag out of the electronic patient health record. But I think that is a real challenge. And I hope that our outcomes research working group of OECI might be able to help with that particular challenge. Thank you very much. So, Lena Trien, turning to you, what are your main challenges?
As has already been said, I'm coming from a Baltic country, which can be said it's also a small Eastern European country with a population of 1.3 million, so we are quite tiny. And we have 3 cancer centers, so I'm representing one of these 3 cancer centers in a small country. And of course, we have the similar problems that have been mentioned already, but I would say that, and I'm not going to repeat these, but there are some very basic and core things that we are struggling still continuously all the time. So does our organization has quality culture in a grassroots level? Does everybody understand what we are doing and why we are doing? Does every single person who has to input, who is in a contact with the patient, understand that this is not something timelines or numbers set by the board, but this is just to give the best possible care for our patient. That is, or this accreditation system, which is wonderful, wisely set up, comprehensive. This is in a way a tool to move toward a better patient experience and care. This is something that we have to work all the time to make it continuous. Of course, we have lots of human resources problems, as probably also most of you here. We are constantly in a lack of cancer nurses, radiology technicians, oncologists, and this causes a lot of quality issues also. And this is also related to budgetary issues. So of course, we don't have so many funds to hire, for example, nurses as much as we would love to have. And there goes lots of other problems also for protected time for research. This is something that we actually don't have. And research is something I would say is a huge problem in my part of the world. It has become much better during the last 2 years within this European cancer mission and all these projects. Yes, participation of widening countries may seem a bureaucratic thing, but for us it does matter. It has changed the world a lot. And even if we don't coordinate or lead a project, if you're just in a group who is doing these things in a European level, it helps us a lot, I guess. But what is still open matter and a huge problem is access to clinical trials. Our patients don't have the access to clinical trials to the level they should have, actually, to my mind. Small countries are not attractive to pharma companies, and so they're not interested in opening trials. Also, academic trials, we would need protected time for that. We would need funding for that. This is also an issue. So I think this discussion we have opened, and this needs maybe collaborative effort to change the world, to at least Europe, to provide also patients access to clinical trials also from smaller countries. So I think it can be done. We just have to start it and do it. Yes. And of course, all the things that have been already mentioned, more in details, they definitely are also problems for us.
Thank you very much, Lena Train. Obviously, OECI, I was going to say that OECI can't do much about the money, about the budgets. But
Yeah.
I do know one example when a centre which had opportunities identified by the OECI process of having under-resourcing in radiotherapy equipment and radiology equipment, took our report, thumped it on the desk of the Minister of Finance or the Ministry of Health and said, this is what an independent certification authority is saying. And actually they did get funding for new equipment. But I think that's exceptional and unusual, so I can't always promise that.
Yes, I would say also you cannot give us nurses or money, but you can share experience and excellence, how things have been organized in other countries. And it's a practical tip indeed. If I go to the board or the financing body and say that we have taken the obligation to, within this improvement plan, and we need to allocate funds also with this. This is a strong word and tool to use. So this is definitely how OECI can help us, and has helped us at least.
Thank you very much. And so, Frédéric, you're the boss of a very prominent Unicancer Centre in France. What are the main issues really facing you as a director?
I'm director now for more than 10 years, and I'm a pathologist, so it's not very natural for a pathologist to be head of a cancer center. Of course, as all the people around the table, I think our main concern is financial, always, to be able to renew all our equipments, to hire enough staff, to have enough nurses, enough doctors, to work in good conditions, to reduce the delay and everything. But what I have learned from the OECI experience, and what was very important for us, is that it gave us the opportunity to take a step back and to analyze our practice. Because in fact, we work, we see patients, we do things, we have a lot of clinical trials, we are involved in research and everything. But in fact, we don't take time to evaluate our practice. And I think something that was very important for us during the evaluation period and the visit, and now we are in the answer process, and I worked late last night on that, is we really need to do that. It's very important at one moment to stop, to evaluate, and to make change if we have to make changes. And this is very important because, of course, we have the direction, general director, deputy director, and all the direction staff. But what is important is now to have the empowerment of the different departments. So we try to do that already since 5-6 years, to discuss the budget and everything, but not to be only budget-centered, but also practice-centered. And I think it's something that is really very important because, as it has already been said, we have, especially in my country right now, a major crisis in health, health management, hospitals. We have very big discrepancies between public and private in terms of salaries, not only for physicians, but also for nurses and other healthcare professionals. So we have a lot of expectation from our colleagues, and they need to, if they work in a cancer center, they need to understand why they are here, and they are not here by hazard. They are working in a cancer center because they want to take care of patients with cancer, so it's really a very important meaning for them. And I think that we don't take enough time to analyze what we are doing in everyday basis, and it's the same thing in research, in fact. We work, but sometimes we don't have the impression that what we do is applied, or we don't see the result on the field. So this was something very important. And if I can speak more widely about France. The National Institute of Cancer wants to apply standards for cancer centers, but that are different from OCI centers. And they want to lower the standards to be able to embark more people. And I don't think it's a good move, in my opinion, because we are a healthy country with a strong social security. Cancer care is free for the patient. They don't have to think about, do I have enough money to pay for a treatment and anything? And because of that, the hospitals have to raise their standards for the care. And I think that at Unicancer, the vast majority of the centers will be or apply to be OCI Comprehensive Cancer Center certified, and I think it's a very strong signal for the other hospitals to say you should go for these standards and not go for the French standards. This is very political, I'm sorry, but I think it's very important for our country. We have the ambition of being a strong country in research, in oncology, and we don't need to have lower standards than EOCI standards.
Thank you for saying that, and thank you for actually introducing the idea that a peer review is not a burden; it's actually time to evaluate. I like that theory that it's a process by which clinicians, other professionals, can evaluate their practice against an international standard and an independent process.
Yes, it's really team building because it gives you the ambition, of raising your standards. And one of our weaknesses in France is the problem of cancer registries. And maybe we should think, at least in the Unicancer centers, to have a common cancer registry. That could be important. We have the IT possibilities of merging our patient files and our data. So I think it could be important as a model. In fact, we have been copied a lot already, but for the good, of course. But I think this is something that is very, very important to have these cancer registries.
Thank you very much. So, Gennaro, would you be so kind as to give us an Italian perspective on these challenges? Do you notice some commonalities or some differences with what other speakers have said?
I would like to focus on a couple of issues in particular. One which is, in my opinion, typical Italian, and the other is more general. So I come from a public research center. And as a public research center in Italy, there is an issue of alignment of priorities in the top management of the institute. Because as a scientific director, I am being appointed by the Ministry of Health, while the general director of the institute is an expression of the local regional government. So there are these two, and the general director, when he or she comes in, brings also the medical director and the administrative director. So there are these two components that have to talk to each other and align their priorities, which are basically from the start very different. And also I would say the type of background is different, because as scientific director in general, we are obviously researchers and therefore naturally prone to international collaborations and looking at Europe as our forum. While the general director, being expression of the local regional government, he or she has the responsibility of the budget of the institute, in general has a more local perspective. So it is important to work around these issues, and it is not easy. It's not easy also to understand how OECI can help in this. But for this purpose, it's important, and this OECI can help, to build a local infrastructure which is stable over time, which does not depend upon the momentary scientific director or the momentary general director. And so there are some things that have been mentioned this morning which are very important. Auditors. So building on a big amount of auditors, so improving, implementing a stronger auditors program. For example, if I could have at my center 10, 15 trained OECI auditors. The auditors, in my opinion, if they become auditors, afterwards they become ambassadors within the Institute of OECI. I think this is an important investment that should be made, together with the toolbox that you mentioned, but also a possible proposal is that OECI may organize dedicated courses for training upon specific issues. For example, so you have the vision, obviously, because you run the accreditation program. You know which are the criteria which overall Europe are more difficult to be the standards to be achieved. Maybe you can take a subset of criteria and build a course, a workshop around this. I think this will be a great success, and many people from all over OECI will participate and attend these courses. So this is the one aspect I wanted to talk about. The other is about the use of data. The use of data, we obviously in our hospital generate a lot of data, clinical data and research data, and the difficulty for everybody is to do a well-organized outcomes research. In this respect, OECI, and I have to recognize that Thierry Philippe has this intuition several years ago, to build up a sister organization on outcomes research and real-world data, which is DigiCore, which I've been coordinating for the past 3 years now. I'm not anymore the president of DigiCore, but I think that DigiCore gave me the frame of mind that we need to invest internally in our centers, and we need to work collectively to build the community of federated institutes which works at the quality of data in order to have them in a proper format to do federated research, in order to put together our data to create a bigger impact that we are able to do now. And with this small publicity to DigiCore, I think it would be nice for the future development of DigiCore if more centers coming from OECI are joining DigiCore, because it's a nice perspective.
Gennaro, thank you very much. I'm really pleased about the shout out for DigiCore as well, which sort of came out of the OECI fold, but we don't compete in any way with their activities. So thank you for that. And thank you also for the ideas around education. Yes, we do have a heat map of those standards that are less well scored. We know that of the 80 centers, so we can easily work on, well, how to build capacity and help centers in those which are found to be more difficult. I mean, sometimes actually when we revise the standards, we realize the standard is wrong. The standard is asking, the wrong question actually about quality. But very often, if the standard is right, and patient pathways is often the one, just to pick one, right, which I know is not so well scored throughout. And it's not just complex pathways involving different institutions. It's actually sometimes a pathway within one institution, and how much is palliative and supportive care really built in and integrated with that patient pathway, for instance, is often a question. Thank you very much. So, John, turning to the Republic of Ireland and the challenges and opportunities that you have in that wonderful island. for cancer?
Well, it's great when you come from a small island, off a small island, off a small continent. And particularly when you're a Mediterranean people stranded in a small island in the North Atlantic. It's very nice to know that everybody has the same problems. I mean, that's great. So I'm going to ignore all the problems that have been outlined already. Staff retention, etc., funding, how do you pay for drugs, dealing with central authority. I'd like to make a couple of points about this. I think that we underwent accreditation first in my institution in 2019, and we're due accreditation again. And your institution changes over time through the accreditation process, and the issues that we face now are different to the ones that we faced in 2019, I think, and there has been evolution of how we've done our business. I think governance is really important, and I think governance is something that needs a lot of attention when you're going through accreditation for the first time. And you mentioned about stability of governance in the context of changing personnel. So when you're bringing a university and a hospital together, and we brought a very big hospital by Irish standards and the number one university by Irish standards, research university by Irish standards together, they have totally different cultures, and they have totally different ways of doing things. And your ability to overcome that and bring them together is quite dependent on the most senior people in the institutions being bought into the project. That's really important. And you have to try and ensure stability when that is a factor. Provosts of universities change, CEOs of hospitals change, and you have to have a structure in place that can withstand that, and I think that's very important. The second thing I would say is that you need, in governance, and we've found this, independent people who are separate to the university and the hospital, but have some relationship with it. So, for instance, the chair of your governance committee is extremely important, I think. We found having an outside chair with immense experience who has relationships with the hospital and the university at a very high level, but isn't actually part of them, is very, very important as well. So I think governance is very important. And I see OECI accreditation process, which I'm a huge fan of, for the reasons that you outlined, its comprehensive nature, is all about quality. Everything is about quality. I mean, it is entirely about that. And what it brings, of course, to an institution like ours is focus. We focus now on cancer because we have this project that we have to do. And when we started back in 2016 with a view to being accredited in 2019, there was resistance to the process because people said, well, it's going to cost a lot of money, as somebody said before. It's going to take a lot of time. But ultimately, my colleague who's here, Professor John Reynolds, saw that it was the only way in which we could get international validated approval for what we did. I mean, it's fine to say we're fabulous, but you need somebody from the outside to come in and accredit you. Now, when you do that and you get through that process, that then becomes an attractor for new personnel, for outside engagement with research, for outside engagement with clinical trials, and gives you credibility and possibly some agency when you're trying to deal with your funding authorities in your country. So I guess those are the things that I would like to say, separate to all the other issues that have been brought up, which I think are unfortunately universal for all cancer institutes.
But John, that idea of an independent chair is a really interesting one. It's not very often followed. In English hospitals, there's a kind of weird system above foundation trusts of a board of governors, which has public representation also, which kind of scrutinizes the work of the executive board of the hospital. But for a cancer center specifically, that's a really excellent idea to actually have someone as a professional chair, not an oncologist. It's a really interesting.
We found it incredibly useful.
Yeah.
We're sort of looking at our governance board at the moment with a view to going through accreditation again, and we think that when we initially went through accreditation in 2019, the governance board was very internally focused. It was very looking at our internal processes. It was the university and the hospital with representatives looking at how we were doing our business. As we have evolved over 5 years, we feel that in the next 5 years, we'll spend an awful lot of our time looking outside the institution. Collaborations and formal legal agreements with research organizations, etc., will be a lot of what we do, and we're going to need more external scrutiny of what we're doing internally. So we're going to change our governance board. And I think that an independent, highly experienced chair So we're lucky in that we have a chair who is retired, extremely senior government civil servant with immense experience at the highest levels in finance and health, with a very benign attitude to what we're trying to do, who's very there to help, is incredibly important in that context. They have access to the highest levels of the university, they have access to the highest levels of the hospital, and they have credibility. I think it's a very worthwhile thing to do. Can I just make one further point? I see OECI, from the presentations this morning, evolving very much in the area of collaboration, education, support, and I think that's incredibly important as well. And the lessons that we learn from accreditation through our auditors who go elsewhere and come back and say, this is really bad, done here, we need to do it better, etc. Should we almost formalize to some extent, and the notion of the toolbox and the experience that other institutions bring to these issues can help other people as they start to go through the process. And as I see that evolving, I think that's a really, really good way of proceeding over the next few years for the organization.
Thank you very much, John. And just to give everyone some warning, I do want to open for your questions to these eminent leaders in a few moments. There's just one supplementary question I'm going to put for a brief answer to actually to anyone who wants to shout out on that answer. But please do be prepared to ask questions, and the microphone will come to you. The specific question I just want to ask you is, you know, accreditation is a process involving standards, but when you come to reaccreditation, and you might think, although some commentators have said that organizations change, and sometimes we have seen a couple of occasions actually where standards fall back because of lack of leadership or a change of leadership or sort of, you know, lack of stability. But in the main, cancer centers continue to improve, and our standards also become slightly more ambitious. But on reaccreditation, we are asking ourselves, how can we, as an accreditation designation team, add value to your center? There's a growing science called appreciative auditing, which is even less of the tick boxing. But it's kind of, you might like to consider, you know, so it's not that you've not complied with any particular standard, and this is, in a sense, it interfaces, I think, with this whole idea of sharing good practices. Would you like to comment on that? What you think would add more value to your center in reaccreditation? Anyone can contribute to that? Yes, Johanna.
So I think that it's very important that it's continuous improvement, because during the first round we probably, and we reached certain goals, but then the improvement plan was the guiding to the following period. So I think it's never, we are never ready, we are never reaching everything, and the world is changing. So I think it's very important to keep on having the reaccreditations. And also we were, in that sense, lucky that, of course, we were not lucky that the pandemics came, but we were lucky to be able to answer to the questions, react to the improvement plan. We received an extra 9 months or something like that, and it was very valuable. So I think that it would be good to have a long enough period for the final visit between the evaluation of the improvement plan. So then you get a good timeline to really reach that goal, or those goals that were the most important ones during that accreditation.
Thank you, that's great. Josef.
If I may add on Joanna's points, I think that, you know, we are in a very unique momentum, especially because of the plans of the European Union with the Beating Cancer Plan and the Cancer Mission as well, promoting cancer research as a major area of improvement on the quality of citizens in Europe. But I fully agree that this is a continuous and dynamic process. So the accreditation itself, it's a timely and a checklist, right? But I think that what is important, and you do that, perhaps even it can be improved, is that you continuously ask for improvements, right, and for comments on the previous assessment, right? Another way to do is participation in the different working groups of OSI. I think that they tackle very important problems, the challenges that we have in the institution, right? And this is something that on on a yearly basis, institutions can participate and also promote actions at the individual institutions. And also participating, of course, perhaps in some of the EU calls that relate to the area. And tomorrow we are going to be discussing on that, the challenges that also it poses, right? But I think that for me, the key message is that this should be a continuous and dynamic reaccreditation, not a process that starts at the 4th year, right? No, it's dynamic.
A dynamic process rather than a two-dimensional static process. Thank you. Any other comments on how reaccreditation can be of more value to you? Gennaro,
Yeah, I would like to make a proposal also in this case. I start from consideration that every reaccreditation or accreditation or reaccreditation is a big examination, okay? It's emotional also a lot, because for the people that receive an audit, a formal audit with 5 people that come to the institute and check all the criteria and so on and so forth is a difficult moment. Obviously, the hope that is going to pass the examination is becoming positive is important and so on and so forth. But in order to attenuate this, maybe, and this obviously would require putting resources from the OACI side, it would be nice a sort of midterm review, informal, probably not the entire audit team, but a couple of people very well experienced coming from maybe from the previous team to visit the institute and to check in an informal manner how the implementation program is going on. I think this would help. I know that there are continuous interactions because the updates about implementation plan have been sent, but this is very distant. It's being done between the individual institution and the central office in the Netherlands, but it's not a direct interaction. Therefore, I would propose that if we introduce a sort of midterm informal review made as a sort of informal audit, this will help a lot in making an assessment of how the implementation plan is going and help in addressing the most critical points.
Thank you very much. That is a great idea, and I'm a great fan of human contact and personal contact. And in our very video conferenced age now, I think traveling to people. I'm sorry about the CO2 global warming thing, and I take lots of flights myself. But actually, to visit, for teams to visit one-to-one and talk personally, and as you say, informally about what's going on, I think is really valuable. Any final comments on that before we throw it open to the floor?
I'm just thinking about telling our staff about the extra visit that's going to happen. I'd be delighted to hear that.
Yes. Provided the Irish pubs are open, I'm sure we'll have a great time. Elena.
Yeah, I was just thinking of sharing our experience. One thing that I like really about this system is that you don't have to have everything perfectly ready if you apply for accreditation. So if we applied for our first accreditation, it was 2015, we were not perfectly ready, and the Cancer Center was actually established after we got this initial this accreditation. So it was open, so you had to have overview, what do you have? And then you had to have the plan towards what you want to move and what are you planning to do to move closer to this European top standard. And for us, the reaccreditation is definitely more demanding. Have you really managed to achieve your goals? How far actually you are? And I think just the first accreditation, it wouldn't have been maybe enough. So it pushes, it's a boost for your whole system, for the quality system, and you definitely look a bit differently. You take the time, you step back, you exactly examine what have you managed, what have you achieved, and then of course, it turns out some things you haven't. And then you again start planning and you put all these things into your new improvement plan. So as Johanna said, it has to be continuous, it has to be dynamic. This is because the world changes. And so I think it should continue like this all the time.
Great. Thank you very much indeed. Anything to add, Frédéric?
Well, I'm not in the process of accreditation,
No.
but in France, we have an accreditation of the hospitals every 4 years by the Ministry of Health. And it's completely different because it's really based on security, security management and processes. And here, with the OCI, you have all the aspects of care in oncology, and I think it's very important because it's really focused also on nurses, on patient empowerment and patient participation, on research and how research is integrated in the hospital. And those aspects are extremely important because it's also what makes the difference. So I think that this type of accreditation is really more adapted to our practice and to our goals as cancer centers. Of course, security is extremely important, and I don't want, and it's also evaluated in the accreditation, but I think it's something that is more also engaging for the healthcare practitioner because they recognize more their practice in the OCI accreditation pathway.
Thank you very much. It is true to say, and we're sometimes challenged by this, by the International Society for Quality in Healthcare, who regulate our standards, by the way. You know, what are you doing about infection control? And we say to them, well, look, we are a secondary or even tertiary accreditation system. We expect the basics clinically to be in place in terms of safety of patient security, etc. And we are adding that upper level of stretching quality for cancer patients. That's what we're about. So now open to the floor for questions. I see here in the front our president has a question. Please, a microphone here to Giovanni Apolloni.
Thank you very much, Simon, and thank you to the panelists because the discussion was very interesting and very fruitful. I would like to make a reflection and also rephrase a final question about the role of OCI and the OCI accreditation system and program. What we are seeing now is a change in the complexity and in the case mix of cancer and healthcare cancer in most European countries. I think that 4 points are very relevant. The first is the increase, Johanna quoted the increase of the number of patients because our non-capability to control the major risk factors at individual level and because of the aging of the population. It means that in the future there will be a very impressive increase in the number of new cases. And also what we are increasing is the prevalence of patients that had cancer that we treat. Sometimes we cure, but of course we are increasing the number of patients in a sort of stable, I'm optimistic, chronic situation. They are patients with diagnosed treatment, but we cannot be sure that they are cured. And these patients are still patients entering for the entire life in the need to be monitored and so on. It means that there will be an increasing of the cost of cancer care, not only due to the cost of the new drugs, but the need of profiling the molecular characteristics of the cancer in order to be sure to give the best treatment or the personalized surveillance strategy. And of course, the last point that increase the complexity of the cancer scenario is the presence of determinants of inequality that are related to economic and financial factors that can hit the process we are talking about at macro level, so the decision at the national level to allocate a given amount of money to our national health service or health system at individual level. Because in several countries, for example in Italy, about 35% of any episode of care in cancer and non-cancer are paid out of pocket by patients, and the capability to spend generally is not uniform between countries and within countries. So I think that now at the very end, after this reflection, I think the very question is, are we so sure that the structure and functioning of our cancer center and comprehensive cancer centers are appropriate in this change of the population, of the need? And of course, do we have to think about a change also in our way of offering standards of care, so the accreditation?
That's great. I mean, what a huge question. Do we think that the structure and functioning of our cancer centers and comprehensive centers is fit for purpose as we're moving into the future with these changed dynamics and case mix and prevalence of cancer? Great question. Who would like to be the first to, Johanna?
Well, I would like to start with Gerito oncology, because we have been prepared for that, the rise of especially elderly cancer patients in Finland. We know that the rise in the coming 15 years is in persons more than 75 years. And we are lucky that our professor in palliative care, Tiina Saarto, who used to be the leader of the working group, so she developed a polyclinic for those patients already more than 10 years ago. So I think it's very important when it comes to the elderly patients to evaluate whether they tolerate the treatment or not. So they shouldn't be undertreated but not overtreated either. So I think that is one thing that we are prepared, but for the rise in the patients, so that is something that I think we should together as the society keep that discussion within Europe. It's very important because no cancer center can alone solve that problem.
Perhaps if I, please go ahead.
Go ahead.
Well, at least in our country, something that actually helps on that, on the situation of survivorship, on the situation of patients with chronic diseases are the national cancer plans and the regional cancer plans. So I think that they try to understand a little bit more the complexity and the situation on each country or in each region, and try to develop these programs as the situation of cancer patients evolves over time, right? So there are new challenges, for example, the adolescents and young adults situation, something that has been implemented. So we have to be aware that we will continuously have challenges. Probably OSI should have a voice on that, on the challenges, but I think that in part actually this may depend on the regional and national cancer plans, right? And another thing that I want to mention, and I think that it's critical, also going back to the previous point on the accreditation, is to promote as much as possible that the quality departments and institutions actually tackle all the metrics over time. You know? And I think that at least this is what we have done at our institution, so to promote as much as possible that the quality department takes care of all the different metrics and continuously evaluate how they move and make changes over time. So I think that this is a critical point.
Thank you. John?
Yeah, I think that we have a tsunami that we have to try and deal with, population aging and, in our case, population increase. I think just like professionals have to work to the top of their license, institutions have to work to the top of their license. And I think in the future, we all know that a doubling of the number of cancer patients means a quadrupling of the resource required because people are living so much longer with expensive modern therapies. I think cancer centers will evolve to focus on complexity, initial diagnostics and treatment planning, and the complex therapy of surgery, radiation, but I think survivorship will have to move out into the community. I think that's one of the things that we're really bad at, which is working with primary care, because of course they're in crisis as well, and they see extra work and they look at it and they say, I'm not funded to do this, and we have to fix that. That's obviously a governmental problem. But I see cancer centres in 10 years as focusing very much on initial care, initial treatment planning, complex therapy, and trying to move everything off-site that can be done better elsewhere. And I think we have to accept that. The more constrained your institution is, the more that's a priority for you, I think.
But John, just developing that point, you would presumably support the thesis that even if that care is much more pushed into the community, then the connection with the acute centre is still retained in terms of
it's going to be much better if you do it that way.
Yeah.
But, data reporting, qualities, all that kind of stuff has to be there, but we just can't do it. I mean, on a global scale, we can't treat all of these patients. Prevention has to be a governmental priority. The problem is when the next economic crisis hits, that the first part of the health budget that's going to be cut is prevention, because it doesn't affect real voters today. And that's another problem.
Anyone else like to build up on that point, Gennaro?
My comment to the previous discussion and to the point raised by Giovanni is that obviously we have to look more and more at cancer in a holistic manner. We cannot confine our work to build the most beautiful comprehensive cancer center, because a single comprehensive cancer center cannot address all these issues. We have to work as a network. So I think the future will be towards comprehensive cancer networks and comprehensive cancer infrastructures, because this is our future. We have to think that this model is what we have to implement everywhere.
Thank you very much. And Frédéric?
Yes, in our center and in many unique cancer centers, we cannot follow all the patients. So we have built networks, labelized networks of gynae, of radiologists, for instance, for breast cancer, who follow the patient and readdress the patient in case there is any problem, because we cannot manage a follow-up even for 5 years for the patient with breast cancer, for instance. So I think those networks of care, of screening are extremely important for the patient, because sometimes they have the impression that we abandon them, and they have trust in their physicians, and they want to be followed in the institution, but that's not technically possible. And the problem is that if I take the example of my hospital, only 30% of our patients are from the area. For many of the patients, they are 1 hour, 2 hours, or 3 hours drive from the hospital. So we have also to organize, when they come to the hospital, many things, which is not financially interesting, but we try to reduce their transportation to the hospital. And for the survivorship, I think it has to be pre-organized in the hospital, and then it has to be outside the hospital also, but with a lot of connections with our healthcare professional. And I think the second aspect, and it will be the plans for the next 10, 15 years, will be also, at least in the Unique Cancer Center, we are going to focus a lot on prevention. We are going to develop an initiative what was built in Gustave Roussy. So trying at least to focus on high-risk patients, high-risk persons, not patients. But prevention will be also a very important task of our centers in the next 10, 15 years to develop.
So glad to hear that collectively the Unique Cancer Centres have the resource and the intellect, and actually in terms of the epidemiology and the risk factors, that's to do that. That's great, fantastic. And a final word to Nesrine.
Yes, if I understood correctly, the second part of the question was also about the equity of cancer care across Europe. This is something that absolutely is there. If we're talking about the access to new drugs or innovative therapies or clinical trials. So, but how OECI can help here? I think we heard wonderful example by Latvia. So we know how the situation is, we know the problems, and then your experts really come and help us to sit around the round table with authorities also, and to make a plan how to improve. And I can see this as a huge advantage and a huge perspective for OSCE to change the current situation, at least for all these eastern small countries. So, thank you.
Well, and thank you. And I want to warmly thank all our panelists for some great contributions. It's been very revealing for me and for us at the OECI as we plan forward. And I think to the whole audience as to, what the insights into some of the big issues that are going on, which we all share in cancer centers. So please, thank you. Do raise your hands, and thank you very much. Well done. Great, thank you.
Thank you.
And I'm really proud to say we're exactly on time. And time for lunch. We have 1 hour for lunch, and see you back. Thank you.